autonomic nervous system, this topic, has immense importance to the practice of medicine. And you all are about to be out there soon, a lot sooner than you think, seeing patients and having to make complex medical decisions. So I like to sort of take a little bit to show you the direct connections between autonomic nervous system and the medicines that we use to affect it. So like my last point there, this isn't physiology, okay? This is really pharmacology and clinical medicine, but I want you to see how this matters, okay? So we'll talk about some of these. All right, albuterol. Albuterol is the asthma rescue medicine, right? When you see people on TV with their inhaler, right? This is usually what they're taking. Albuterol is a beta-2 adrenergic agonist. All right, what the heck does that mean? That means it activates, that's agonist, okay, the beta-2 adrenergic receptor, which we learned about last time, right? Beta-2 receptors are inhibitory. They're found in the lungs. If you activate a beta-2 receptor, it causes the airways to get bigger, right? So it makes perfect sense. In asthma, the problem is that the airways have constricted too much. We blow beta-2 agonist down there, it binds to those beta-2 receptors and causes vasodilation or airway dilation, improves the original problem. So it causes things to dilate, easing the blood flow. All right, so beta-2, there's two lungs, beta-2, right? Beta-2, two lungs, see, two lungs, one heart, right? Beta-1, one heart, beta-2, two lungs. Easy. All the twos, alpha 2s and beta 2s, are all inhibitory, right? So if it's a 2, it's inhibitory. Okay, so little tips. So beta 2 inhibition of bronchoconstriction. All right, so that's one, respiratory rescue. Here's another one that you've undoubtedly heard about, beta blockers, right? Beta blockers are a class of medications. Not surprisingly, they are antagonists of beta receptors. All right, so we have beta receptors in lots of places. Beta 2 found in the lungs, beta 1 found in the heart. Well, what most beta blockers do is they inhibit the beta 1 receptor preferentially over the beta 2 receptor. In other words, beta blockers reduce the workload on the heart, okay, by turning down the stimulation. Now, why does that matter? Well, they did a huge study. Most of our cardiovascular medicine today is the result of gigantic studies with millions of people, right? Well, one of the things that was discovered is people with heart disease died less if they were on a beta blocker. Gotta love science like that, right? So they even stopped the study early because the difference was so big. So if you have cardiovascular problems, a beta blocker is in your future because we don't exactly know why it keeps people from dying, but people who are on beta blockers die less often than people who are not on beta blockers. So we put them on beta blockers. Now the problem is, if you're an asthmatic, you potentially have a problem because you are now blocking the very receptor that you use to save the asthmatic. Okay, so it doesn't mean you can't use a beta blocker in an asthmatic, but you'll use one that is very selective for beta 1, right? So that it's not affecting beta 2. All right, so that's the beta side. Alpha blockers. Alpha blockers are occasionally used to reduce blood pressure because they block alpha 1 receptors on blood vessels. Alpha 1s are stimulatory, right? So alpha 1s make vessels contract. If you block the vessels from contracting, they get bigger. Bigger vessels have less resistance, lower blood pressure, right? So we can use these to lower blood pressure. Now, the downside of it, we don't use alpha blockers and blood pressure very much because when you change body position and you're on an alpha blocker, you have no way of changing your blood pressure to match. So you get orthostatic hypotension, right? Stand up too fast, go down, syncope. But one of the things we do use these alpha for is alpha blockers. They are very good medicines for benign prostatic hypertrophy, so enlarged prostate gland that men over 50 will sometimes develop, right? By stimulating the by blocking the alpha receptors, we are able to reduce some of the symptoms of BPH. So there's another one, alpha. Pseudoephedrine. Oh wait, do I have it? Yeah, there we go. Pseudoephedrine, Sudafed, right? This is a little bit more complicated of a mechanism. Okay, so this doesn't directly affect the sympathetic nervous system, but it affects something that does. All right, so pseudoephedrine causes the release of norepi from postganglionic sympathetic neurons. All right, in other words, it causes the release of epi at the end organ effectors. So it stimulates epinephrine production. Now, why does this help us with our congestion? If we vasoconstrict our mucosa, the vessels going to our mucosa, they'll make less fluid. Less fluid means less snot. Less snot means you're a more comfortable patient, right? So pseudoephedrine, Sudafed, works by stimulating the sympathetic nervous system. Now, downside, there's always a downside. This can result in elevated blood pressure. Patients who have high blood pressure should not take Sudafed because it will increase their blood pressure, right? The other thing that can happen is you can end up with a rebound effect where you take Sudafed and then at 4 hours it starts to wear off. Well, as the norepinephrine release starts to drop, those vessels dilate and now you get a whole bunch more snot where it had dried up pretty good, right? So that's Sudafed. Epinephrine is our most important resuscitation drug, right? You know, you see it on TV all the time. Push epi, push epi. It's real. That's pretty much what we do. Like if your heart's not beating right, or you're unconscious, we are probably going to push epi on you. Why? Because epinephrine is the sympathetic nervous system's big hitter, right? So epi is the very same thing that's released by the adrenal gland. Now, when we give somebody epi in a resuscitation environment, we give like 100 times more than the adrenal gland can put out. So it's a big whopping dose. And we'll give it every 5 minutes until you come back around, or we call it. You'll learn all that in your ACLS this, when do you do ACLS? December still? Okay. All right, so that's epi, pseudoephedrine. Alpha-1 agonists. Phenylephrine, nobody calls it that, they call it Afrin, right? Afrin is the nasal spray. You spray it up in your nose, and if you have a cold or whatever, then a couple of 15, 20 minutes later, you can breathe nice and easy again. Why? Well, kind of like Sudafed, but a different mechanism. Here, phenylephrine is a direct alpha-1 agonist. In other words, where Sudafed causes an increase in epinephrine release, Afrin directly vasoconstricts the vessels to your mucosa. So it's a direct effect. It's very effective at reducing congestion because you're basically starving your mucosa for oxygen. The downside is there's significant upregulation that occurs. So it goes a little like this. You have a cold, you use Afrin, it makes your congestion better. So you do that, every 4 hours for 6 weeks, right? Well, then you stop the Afrin, and now suddenly your vessels can work properly again, and you get more congestion than you've ever had in your life. So then what do people do? Oh, well, I need my Afrin, right? Now you're addicted. See, it's not an addiction of, ooh, this makes me feel great. It's an addiction of, if you don't keep using it, your congestion gets worse and worse and worse. Yeah.
So when some people, if medications like that don't actually work, does it show that they have some kind of issue with their alpha-1 receptors?
That wouldn't be the first thing you would think, because they would have like blood pressure issues and stuff. That would be more concerning. It's probably more like that particular patient doesn't have a very vigorous response to it. It's more individualized. So Phenylephrine, and it can also increase your blood pressure. The biggest downside is people get hooked on it because once you start using it, it's difficult to stop. Now, how do you get off of it? You have to just not use it. You have to endure the flood, and the flood will eventually go away, right? You'll down-regulate again, and you'll think twice about using it the next time. Some people just use it multiple times a day for years and years and years. We talked about cocaine and PAF. It's some of the same downsides with Afrin. Not the CNS effects, but the vasoconstriction effects, like it can break down the mucosa and all that good stuff. All right, and then in ophthalmology, we use ANS effectors a lot, right? So alpha-1 agonists are used to dilate the pupil. Acetylcholine is used to constrict the pupil. If you've gone to the eye doctor, they've probably used the first one. The latter, constriction, is done in patients with glaucoma because it actually increases the movement of fluid.